Thank you for tuning in today to hear from a panel of distinguished volunteers to discuss COVID-19 considerations for resuscitation. I'm Heather Alger, National Director of Research Bioinformatics at the American Heart Association, and with me today is Dr. Donna Edelson, a hospitalist and Executive Medical Director for Rescue Care at the University of Chicago and co-founder of Agile MD, a clinical decision support and predictive analytics startup. She's also the chair of the American Heart Association's Get With the Guidelines Adult Research Task Force. Dr. Gustavo Flores is a volunteer member of First Response EMS in Puerto Rico. He has served as an AHA ECC volunteer for many years. Dr. Vinay Nadkarni is a pediatric critical care physician at the University of Pennsylvania Perelman School of Medicine and Children's Hospital of Philadelphia. He has previously served as a volunteer chair of the American Heart Association ECC and of ILCOR. American Heart Association has received many questions from healthcare providers just like you on resuscitation issues emerging in the COVID-19 pandemic era. Thank you so much for joining us today for this opportunity to discuss these important questions. Let's jump right into the questions that we've received. The first is, in an effort to limit exposure and conserve PPE, several hospitals are currently evaluating the number of team members that are in a room during a resuscitation for COVID and keeping the other members of the team outside of the room. What are other hospitals currently doing? And Dr. Edelson, I'll leave that one to you.
Sure, thanks for having me. Happy to answer that question, it's a great one. Obviously, the best way to protect rescuers is to avoid exposure entirely. So if you're not essential, you should not be in the room. The question of who's essential, though, is a difficult and a moving target. And I will say that historically, this is very different in the in-hospital setting than it is on the out-of-hospital setting. In the in-hospital setting, we often struggle with way too many people and crowd control, particularly when you call things overhead and everyone comes running. And so even just getting to a manageable number is a huge win for us. I will say that probably before COVID, it was not unusual to have to be pushing people out the door and to have upwards of 10, 15 people in a room. In the COVID era, we need to be much more careful about it. We probably should have been more careful about this before. I'll say that we need folks at the airways. So probably before intubation, you need 1 to 2 people at the airway. Chest compressions, we still need to deliver high quality chest compressions and people still fatigue. So you need 2 to 3 people rotating on chest compressions. And then you need somebody running a code. You need somebody administering medications. And most everything else can be left outside. I'll say in our hospital, we leave the pharmacist outside the door and the crash cart stays out there. The recorder can be at the door further away, but still needs to be in PPE to be able to watch what's going on. And for the most part, we're able to manage to keep fewer than 8 people in the room.
Donna, I think that's really important. Using choreography by doing some simulations, we've been able to knock that down. In some hospitals, like in ours, we're also using iPads so that the code leader can actually be outside the room, and that we're keeping the code card and some of the equipment outside of the room and only opening the door or sliding it through a window in order to minimize the risk of aerosolized particles getting out of the room and exposing other people who aren't in full PPE. Gustavo, are you doing anything different?
So in the out-of-hospital environment, it's difficult to limit number of people, especially if it's a public place. We definitely want to make sure that providers are, number one, capable of doing the full code on scene. So whatever it takes to be able to actually do entire ACLS on scene may require moving the patient to a more suitable location. And that may also include the benefit of more air ventilation around so that providers are less exposed. However, we definitely need to make sure that we're also taking care of our providers on scene and making sure they all have PPEs as well. So other than that, non-essential personnel should be kept away.
Donna, one of the things that we've started to do is we've restricted the use of, say, the N95s and the PAPRs, but we want the code team to be prepared. So we've created either bags or spots on each ward which have that material, but the use of that is restricted for the second, third, and fourth person in the room so that everybody doesn't have to always be in those masks. How about you guys?
Yeah, that's a really good suggestion and interesting point. We've gone back and forth in terms of whether to include the PPE as part of the crash cart or as a kit that goes with the crash cart. And I'll say our positioning seems to change based on what the availability is, and also what the stockpiling is happening behind the scenes. We find that when you leave things out, they tend to go missing.
Yes.
And that's been one of the big concerns. So having them in kits that are clear kits that can only be used by the resuscitation team has actually been an interesting and exciting proposed solution to it. But I will say that we struggle in this continually. There's one other piece that I would add, which is we're talking right now about confirmed COVID and PUI patients, but when we think about in the out of hospital setting, we may not be able to know that someone isn't. In the in hospital setting, there are definitely patients that we feel fairly confident have ruled out, are not COVID positive, have not had any other interactions, and so when we think about how to adjust their resuscitation, for the most part, while the algorithms would stay as they were before, there are some changes that we are making, and I'll say that still limiting people in the room is still really relevant to that population as well, and that's really mostly because of social distancing purposes amongst our providers. We want to keep our providers as far away from each other as we can, also because if one of them turns out to be positive, we want to limit the exposure that the rest of the people in the room might have had. Is anyone else doing anything like that? And anybody, are you guys adjusting your resuscitation practices for non-COVID patients or non-PUIs?
Because of community spread, where everybody right now is being treated as a COVID positive patient and all providers are wearing PPE.
And in our hospital, even we've had some negatives that have turned positive. So we are, for the code team purposes, considering everybody COVID exposed. But one of the things you mentioned, moving on to sort of the next question we got, was about the use of mechanical chest compressors. And like, should we be, you talked about limiting people going into the room and maybe limiting equipment that doesn't need to go into the room going in. A number of people have talked about using mechanical chest compressors instead of using humans to do that. And I think we think that it's a good idea when teams are already trained and ready to do that. It's part of their usual choreography, but that because of the potential exposure risk and the difficulties of learning and doing that well, the teams that aren't already doing that or trained up to do it probably shouldn't just go out and buy mechanical chest compressors. Gustavo, do you agree with that?
Yes, absolutely. If your EMS team, your pre-hospital care team is already doing a pit crew CPR approach that incorporates a mechanical device, and you're already it's not only under protocol, but it's also very well rehearsed, very well choreographed. You can certainly incorporate it because it's adding another barrier and limiting the exposure and increasing high quality CPR. But the problem is that perfect implementation requires a lot of training, and when you don't do that training, your neurological outcomes will suffer. Therefore, that's why we are at a fence to recommend it even for regular patients on a regular basis.
Great, thank you. That's some really important discussion. We've also received a question about the use of ventilation with bag and valve mask as an aerosol generating procedure. And it increases the risk, again, of healthcare provider exposure. what should providers do if there's a sudden code blue? What are some of the changes using the usual algorithm that people who are doing to minimize the risk of COVID transmission? Dr. Edelson, do you have some ideas on that?
Yeah, so that's a great point. And so if I take a step back to just summarize the aerosol generating procedures that happen during resuscitation, there's CPR is aerosol generating, intubation, any positive pressure, so that bag mask ventilation, those are all CPR, all aerosol generating procedures. And so, and some of them are potentially worse in the moment than others. The actual moment of intubation is probably one of the highest risk things that we can do in a resuscitation. You have a rescuer in the face of a patient passing the tube. On the other hand, after intubation, when you have a cuffed tube and you're connected to a ventilator, you actually are in a closed circuit, and that's the safest. And so there's prioritization that needs to happen around that in terms of what you can and can't do. So in the in-hospital setting, our priority is to get to intubation with a cuffed tube and a closed circuit with a filter as soon as we possibly can. Gustavo, how are you dealing with this in the out-of-hospital setting?
Well, we certainly have to begin CPR as soon as possible. So we should make sure that providers are starting hands-only CPR before they start prepping for any advanced airway procedures. Some systems are already incorporating hands-only CPR in the first few minutes. So if this patient is a presumed cardiac arrest, from presumed cardiac etiology, doing hands-only CPR would make perfect sense from a pathophysiological standpoint. So that would give EMS providers a better opportunity to get ready, making sure that they got the right equipment, making sure that the most capable provider is ready to do the advanced airway management and obtaining first pass success. And that may take a little bit more time, but we're making sure that it's done right the first time.
And I would say that, Donna, I don't think we can overemphasize enough that when you decide that you need to give that ventilation, that if you're giving it with bag mask, you want a tight seal, whatever technique is best to create that tight seal. And then in addition, when we're intubating, as Gustavo said, the most experienced intubator using the technique that works best for them, like for intubators trained with video laryngoscopy because of two reasons. One, it takes you out of the direct line of sight, so your head doesn't have to be right down by the patient's mouth. We're pausing chest compressions during that intubation event, so we're not pushing down and splashing the intubator. And then also, they're trained so that they can do it quickly with a video laryngoscope. That may not be the best technique for everybody, but knowing what your local circumstances for the best, fastest, earliest intubation without spraying people is what we're going to.
So absolutely agree. And I'll say, so that's all ideal scenario, which is that we can get a tube in easily, that we have a provider that's skilled to do it and has, and ideally is trained and knows how to use a laryngoscope, that's ideal scenario, and we can do that quickly. Now, we all know that we don't always get to function in an ideal scenario, and there are times when there's going to be a delay to be able to intubate. And so in those circumstances, we need to figure out what we're going to do in the interim. And so we're left with that question, well, do we bag mask ventilate or do we not bag mask ventilate? And that's also going to be context specific, particularly in COVID, where a lot of these arrests tend to be hypoxic respiratory failure. It's hard to go a long period of time without any oxygenation. And so while it's compression-only CPR is very appealing for short periods of time because because it's going to minimize aerosolization. We're not going to be able to maintain that for too long all by itself. One of the things that we've started doing at the University of Chicago as a temporizing measure is to put people on a non-rebreather face mask with a surgical mask over it so that they're getting some oxygen. We don't know exactly how much air exchange is happening during CPR, but we assume that there's some. And so for a short period of time, that's probably reasonable. If we do need to bag mask, that is a difficult skill, and that requires it requires a lot of care. Ideally, someone who's well trained to do it, but and potentially even two people, one to hold the mask and another to squeeze the bag, has some potential. And then there's always
I would also say that we're.
Oh, go ahead.
So I was just going to say that completely agree. I think we want to reinforce also that those bags, when you're using the bag mask ventilation, you have a HEPA filter on the exhalation valve to try to protect the rest of the room from getting the exhaled gas. And of course, in children, ventilation is probably even more important. So we're earlier to provide that bag mask ventilation with a nice tight seal and the HEPA filter in line.
Yeah, and I think we cannot overemphasize that enough. Any positive pressure ventilation that we're going to give, we ideally would have a HEPA filter in line with the exhaled gas. So with an ET tube, with a bag mask, with the ventilator, if available, a HEPA filter is going to cut down on the amount of virus that is dispersed into the air.
Great, that's an excellent discussion. We actually received some questions about specific patient populations. Many adults with sick lungs are being proned. What are some of the considerations for prone CPR? Dr. Vinay?
I can make a quick comment on that. Yes, because the technique for supporting very sick COVID patients, in adults in particular, involve prone positioning, the patient may already be lying face down, prone, with an endotracheal tube in place. Under those conditions, the AHA actually recommends Class 2B prone CPR can deliver excellent pressures and is a legitimate form of CPR, so it's fine to do that. But again, remember the risk of dislodgement of the tracheal tube is an issue, and it's something that should be practiced and rehearsed if it's going to be provided. Donna or Gus, do you have any other comments on the prone CPR?
I will add the disconnection from the ventilator. So once you're on a ventilator, you have the closed circuit. Every time you open the circuit in any way, it pops off, you're spewing virus into the air. And so we want to be really careful about those disconnections. And so there are a couple places. Vina's talking about the disconnection that can happen just from the CPR, and you've got the patient prone, and so you can't see what's happening underneath. But also if you try to turn the patient, there's a very high likelihood of disconnection, which is why particularly if the patient is adult size, it is hard to turn a patient without getting disconnected. It's very small children, you guys are probably better at flipping over without there being an issue. But in an adult population, prone is probably going to be preferred for a patient who's intubated. Now, we're also using proning earlier in these patients, so it's very possible that you will come across a patient who arrests in a prone position who's not on a ventilator. And in that case, I would flip them over because you're going to need an airway, and that's just going to be easier to do. If you're doing CPR in a prone position on a patient who's intubated, it may be reasonable to have somebody keep an eye on or even hold the connections between the ET tube and the mechanical ventilator to prevent disconnections.
Great, thank you. We've also received questions about the use of universal do not resuscitate, and should there be a universal DNR or not for resuscitation during COVID-19 with COVID patients. Dr. Flores, would you like to speak to that?
Well, we stand by our mission to save patients who suffer sudden cardiac death. Therefore, we definitely want bystanders to start CPR. We certainly want EMS providers and in-hospital providers to do CPR on patients who have sudden cardiac death. The discussion about do not attempt resuscitation in patients who have such a high mortality risk, such as patients, COVID-19 patients who have other comorbidities, is a discussion that should start early on. Patients who are at risk of COVID and have other comorbidities that place them at a higher risk of death should definitely be having this conversation with their providers right now, out of hospital or in hospital, because this is a discussion that should be on record and readily available for providers that are responding to a patient who's in cardiac arrest who should be on a do not resuscitate order. So it is a highly ethical discussion and also dependent on a cultural context, but from a medical standpoint, it is something that has to be talked with patients on the best occasion, which is right now.
Great, thank you for that context. Dr. Nadkarni or Dr. Edelson, anything to add in?
Yeah, I guess I would say COVID-19 in and of itself is not a death sentence. 80% of people who get COVID-19 are have mild disease, and we're thinking there's actually a quite sizable population that actually is completely asymptomatic. And with the community spread that we're seeing, we're going to see a lot of people who happen to have COVID-19, but actually are arresting from the stuff they would have arrested from before. And so, I don't think that COVID-19 in and of itself is reason to to make a decision about starting or stopping a resuscitation. There are other things that we should be taking into account, and we need to, because we have to balance the needs of our patients against the resources that we have, which is our providers and other devices as well. And so it is reasonable to think about risk of the immediate risk and also the likelihood of success. So when we think about who's likely to have a successful resuscitation, that's going to depend on your the severity of your disease in the moment, your age, and some comorbidities. That's all data that we're seeing. We're a long way away, I think, from having really a full understanding of what the outcomes are from cardiac arrest and COVID-19. But there are certainly some things that we can see right now, that increasing age and significant comorbidities do predispose to worse outcomes. But we should also be cognizant of a lot of these patients who are arresting. While there's a lot of hypoxemic respiratory failure, there's also cardiovascular, there's actually a lot of arrhythmias as well. And patients, we know that patients who arrest, even in an ICU on a ventilator with a shockable rhythm, have significantly higher survivals than those that aren't shockable. So I think you have to take a lot of things into the context. And I would shy away from any blanket statements about resuscitation or not, just based on COVID-19 status. Dina, what's your general approach?
Totally the same. I agree. And I think we have to acknowledge that termination of resuscitation rules are going to be local and evolve over time as we understand more and more about this. I do know that several centers, when they've gone into, like in New York, where they have really been under siege and have gone into this triage and sort of wartime kind of approach, they have even assembled a medical expert and an ethics expert who have participated in the triage to try to help, as Gustavo was saying, to predetermine which patients would be appropriate or not appropriate for resuscitation, which would be futile and which would not. So I think that these will evolve over time. We don't have a blanket statement, but on the website, at the end, we'll put up the website as things evolve and as these termination of resuscitation rules evolve. If there is an evidence-based approach, the American Heart Association will certainly make that and disseminate that.
I will say, though, that we should be very proactive about engaging patients in goals of care conversations. These are, again, all things we should have been doing before. And COVID-19 is a good excuse to reinforce this stuff. When patients come into the hospital, we should be addressing goals of care with them. Whenever there's a change in their status and we go up to a higher level of care, we should readdress it. And so we should absolutely be doing that. But also these, as Binay says, these policies are going to change based on resource availability and risk and data as we see it. But I will say that the one thing that health systems probably should be doing is they should be really clear about those policies so that frontline providers aren't making those decisions on their own without any guidance. If, for example, an EMS system isn't, if you're not transporting patients who don't get RESC in the field, that should be a policy that comes from the EMS system and not one that people are making on a game time decision at the front lines.
Yeah. I wonder if we just switch for a moment, we're sort of coming to the end of the discussion and thinking, we've talked a lot about the in-hospital resuscitation quite a bit, and we've gotten some questions about whether the layperson, is there a shift in anything that we should be doing for the layperson or advising the layperson to do that's different from our usual practice of scene safety, call 911, start chest compressions, listen to the telephone operator. Gustavo, is there anything different in that sequence or different about how cardiac arrests are going to happen around the country now?
We want the layperson, the bystander, to start CPR as soon as possible. We certainly need to make them aware of the risk. So EMS dispatchers are informing them that they're willing to give real-time instructions on the phone on how to do CPR, provided that they put some face mask or some barrier for them and also for the patient. That would be the only recommendation. An AED is not an aerosol generating procedure, so we really need the bystanders to do what they can for victims who have sudden cardiac arrest. A cardiac event such as this in a public place is likely due to cardiac etiology. So these patients will definitely benefit from immediate bystander action.
We should also remember that 70% of arrests occur in the house or in a
even more
home.
During the COVID era, it might even be more, right?
Absolutely, right. With shelter-in-place orders, we can imagine that that's going to go up. And so if you're in a household with someone who's COVID-19 positive, you're probably already been exposed. And so the additional benefit, the additional risk to you of doing CPR is potentially smaller. Now, I will say, I say that potentially because we don't know. It's certainly possible that additional exposures, increased frequency of exposures is worse, and we'll know that in the future. But you've probably already been exposed when you're in the house.
And I think we should also mention that for children, the recommendations really aren't very different at all, because most of those times the children who are resting in your home or in the presence of somebody they know need rescue breathing more so initially than the adult who collapses with sudden cardiac arrest. So the emphasis on ventilation is a little higher in children.
That's a great point.
Great, thank you both, or thank you all so much. This has been very helpful information for both the clinical side as well as this last discussion on what individuals can do in their homes and their communities. That's all we have time for today. Thank you, Drs. Nadkarni, Flores, and Edelson, for your time and expertise. We appreciate you sharing your perspectives on safely providing resuscitation to patients while protecting yourselves and your colleagues during the COVID-19 pandemic. We also want to say thank you to our audience who submitted the questions or clinical challenges that they've encountered during this time. Your shared learnings will help inform the healthcare community as we navigate forward together. On behalf of the American Heart Association, thank you all. The views expressed in this podcast do not necessarily reflect the official policy or position of the American Heart Association, the American Stroke Association, or the institutions of the speakers. For transcripts of this podcast and for more information about COVID-19 and resuscitation, please visit www.professional.heart.org/COVID-19 or engage with us on social media using the hashtag AHA COVID-19. Thank you, everyone, and have a good day.